Hi all, today we'll be talking about Charcot-Marie tooth disease. Charcot-Marie tooth disease, or CMT, is the most common inherited disease. It is classified as a peripheral neuropathy, meaning it affects the neurons of the peripheral nervous system, not neurons of the brain or spinal cord. Both motor and sensory neurons are affected by CMT disease, so both motor and sensory functions are compromised. However, it is important to note that CMT disease is more of an umbrella term. There have been over 50 genes identified which can cause CMT disease, and depending on the protein associated with the gene which is mutated, CMT can be categorized further, which I will get into later. A person with CMT disease has either their myelin sheaths or axons compromised, and these affected peripheral neurons will degenerate over time, meaning this is a progressive disease. It is very rare to see CMT disease spontaneously manifesting rather than being inherited, so I will focus on the inherited forms for this lecture. CMT disease can be inherited through autosomal dominant, autosomal recessive, or X-linked patterns, with the most common forms being autosomal dominant. There are 5 major types of CMT disease that I will be mentioning today. CMT1 is the most common form of the disease, and it is autosomal dominant, meaning only one copy of the gene is needed for an individual to express the disease, and those who have it experience myelin sheath abnormalities. Recall peripheral neurons may be wrapped in myelin or not, and if they are wrapped in myelin, it is due to Schwann cells. Those wrapped in myelin are able to conduct signals faster. There are multiple varieties of CMT1, and each of these describe a different gene related to myelin sheath function or integrity which has been mutated. For example, CMT1A is an overexpression of peripheral myelin protein 22, which is a critical component of myelin sheath, while CMT1B affects myelin protein 0, which is another essential myelin sheath component. There are multiple types of CMT2 disease, most autosomal dominant, and the genes affected relate to axon function or integrity. The most common form of CMT disease which affects peripheral nervous system axons is CMT2A, where the protein affected is mitofusin 2, which is associated with mitochondrial fusion. CMT3 is a rare, severe demyelinating neuropathy which begins in infancy, unlike most other forms of CMT which begin to show in childhood or adolescence. It is inherited in either an autosomal dominant or recessive manner. CMT4 is an autosomal recessive disease, meaning both sets of the mutated gene must be present for an individual to have the disease. CMT4 diseases are related to demyelination, which is similar to CMT1 and CMT3's pathophysiology, but the difference is this is just autosomal recessive. Finally, CMTX is an X-linked mutation of connexin 32, a protein expressed in Schwann cells and used for communication between themselves and the neuron. Overall, the pathophysiology of CMT disease can be thought of as a genetic problem with the proteins associated with either the peripheral neurons' myelination via the Schwann cells or their axons. There are many varieties of CMT disease as there are many genes whose dysfunction constitute the signs and symptoms of CMT disease. These signs and symptoms will now be discussed.
CMT is one of the most common inherited neuropathies. Its prevalence is 1 in 2,500 people. The onset of symptoms most often occurs in adolescence and early adulthood, and usually affects the lower extremity first before the upper extremity. Pain can range from moderate to severe. The disease is known for its slow and steady progression. Once diagnosed, a patient may want to undergo genetic testing to see which of their genes was mutated, and it is not considered to be a fatal disease, and most of the time people have a normal life expectancy. Patients may present with some of the following signs and symptoms: complaints of lower extremity weakness, foot drop, foot deformity, sensory deficits which may include loss of light touch, proprioception, vibration, and/or hot and cold sensation, muscular atrophy which may give rise to an inverted champagne bottle look of the lower leg because of the thinness of the ankle area compared to the upper calf. They may also have absent deep tendon reflexes, fatigue, numbness, and there's a few more signs and symptoms listed on our handout. The diagnostic process starts with a standard medical and family history, a neurological exam, which looks for evidence of muscle weakness, decreased muscle bulk, reduced tendon reflexes, sensory loss. The physician will also look for presence of foot deformities, which is shown in the picture on the right. There's a severely high arch due to the muscle atrophy. The physician will also look for possible nerve enlargement and do electrodiagnostic tests. These would include a nerve conduction study and electromyography. And genetic testing may also be done, as well as a nerve biopsy if the previous measures cannot confirm the diagnosis. Diseases with similar presentations will include Friedreich ataxia, spinal muscular atrophy, chronic inflammatory demyelinating polyradiculopathy, don't know if I said that right, and diabetes mellitus. And family history was bolded on the previous slide because a positive family history is a very strong indicator of the disease, making other options unlikely, but of course further confirmation of the disease is still required via electrodiagnostic and/or genetic testing.
Ascorbic acid and a combination of baclofen, naltrexone, and sorbitol, known as PXT3003, have both been shown to downregulate PMP22 expression, as well as help in the formation of the myelin sheath and axonal regeneration, respectively, making them both contenders for a pharmaceutical treatment for CMT. However, a 2-year study by Pearson et al., authored in 2011, showed no significant evidence of ascorbic acid's benefit to CMT1A patients. A 2014 study by Atarian et al. Focused on the tolerability of PXT3003, but did have some significant results regarding its effect on treating CMT in its high-dose group. Both studies found ascorbic acid and PXT3003 well tolerated by patients. As of right now, however, there are still no proven effective pharmaceutical treatments for CMT. The authors of both of these studies emphasize the need for longer study periods in order to truly determine the efficacy of these drugs, especially considering the slow progression of CMT. So yes, these studies surrounding ascorbic acid and PXT3003 did not prove their efficacy. However, we cannot rule them out. In fact, they need further study. This is a figure from the Atarian study that actually incorporated some of the data from the Pearson study, as well as another study that I did not highlight. It's a really great visual of where we are with CMT drug research as of 2014, specifically that there is nothing definitive, but PXT3003 looks promising, and ascorbic acid, while not as promising, is not necessarily worth ruling out. Because there are no drugs that directly treat CMT, patients who have CMT are typically prescribed pain medication to help handle the disease. 2 common pain medications prescribed to patients with CMT are baclofen and Neurontin, otherwise known as gabapentin. Dr. Weyer has discussed the mechanisms of both of these, so to quickly refresh your memory, baclofen, which is commonly used to treat spasticity, is a GABA agonist, so it aids in pain reduction by binding to inhibitory interneurons. Its side effects include confusion, dizziness, drowsiness, weakness, and nausea. Neurontin works by inhibiting voltage-gated calcium channel subunits in the brain. Its side effects include dizziness, drowsiness, and weight gain. An important note regarding patients with CMT and pharmaceuticals is the effect of neurotoxins. Unfortunately, drugs involved in chemotherapy often include neurotoxins, such as vincristine, which suppresses the microtubules involved in mitosis, leading to the cell's inability to divide completely, causing it to die. Patients who have been diagnosed with CMT are strongly advised to avoid neurotoxic drugs such as vincristine. However, the real trouble lies in patients who have inherited a genetic predisposition for CMT but do not have an active form. There have been cases where cancer patients underwent chemotherapy, which then activated CMT within them, including a 52-year-old woman from earlier this year and an 8-year-old boy in 1999. This is where family history becomes vital in treating patients with no neurotoxic drugs. Ultimately, because there are no proven pharmaceutical treatments for CMT, the best option for treatment, aside from pain medication, is rehabilitation, especially through physical therapy.
Physical therapy for Charcot-Marie Tooth patients addresses the secondary motor deficits brought on by the neurological deficits. This includes low-intensity strengthening for distal atrophying muscles of the lower extremity, which also improves the poor circulation due to the lack of muscle bulk in the lower extremity. PT can also address the pain and poor mechanics brought on due to excessive pes cavus, which is a foot deformity often dealt with by CMT patients that results in an excessively high arch that does not flatten out and accept body weight load. PTs will often work on modifying and improving gait patterns, looking at gait training and assessing speed and motor function. Physical therapy can also be preventative, as CMT patients are prone to plantar flexion contractures due to the lack of musculature on their anterior lower extremity. It can also be palliative, meaning that it addresses the quality of life of the patients by modifying their activities of daily life, improving their functional activities such as balance and posture. As an aide, I worked with a man in his early 40s with a CMT diagnosis. Interestingly, he had 3 sons, only one of which was affected with the disease. His therapy mainly consisted of working with his ankle-foot orthoses. They were custom-made, but they were pretty uncomfortable and painful, so they required a decent amount of practice. And then we also worked maintaining the strength in his lower extremities that he already had, and then working with balance to make sure that he was getting his stability from his muscles rather than from locking out his joints. In a study by Dimitrova et al., they found gait, balance, and contracture improvement with low-intensity lower extremity exercise, both in and out of water, using the stationary bike, ambulating with orthoses, and then using galvanic current to stimulate those muscles. And galvanic current is a form of direct current e-stim. Another study from 2014 by Minotti et al. Looked at the effects that ankle-foot orthoses, or AFOs, had on gait for CMT patients with type 1A diagnoses. They took male and female participants, ages 30 to 50, and had them walk 23 meters around the track, first with just shoes and then with the ankle-foot orthoses. Participants were allowed to walk at their chosen speed, with their steady-state oxygen consumption and carbon dioxide measured and compared between the 2 laps. The conclusion they came to was that using the anterior ankle-foot orthoses, such as the ones pictured above, they were able to decrease the physiological work necessary to walk the same distance in shoes only. They concluded that this improved walking speed and distance and was likely due to improved walking mechanics. An earlier study by Rose et al. In 2010 looked at the effects that serial casting can have on younger CMT patients in terms of ankle contracture. They took patients in between 7 and 20 years old with restricted dorsiflexion of less than or equal to 25 degrees. Their goal was to prevent further restriction and increase ankle range of motion. The experimental group wore casts every night for 4 weeks with their ankles held at their own max passive dorsiflexion. This was followed by a 4-week-long HEP of bodyweight self-stretching of the gastrocnemius and soleus. Casted patients showed significantly more dorsiflexion than the control group after 4 weeks, but by the end of 8 weeks there was no significant difference maintained between the experimental groups and the control groups. However, multiple patients were cited as saying they felt the program was very useful and helpful, and they were planning to continue the program even after the study was over. Our research did not reveal any specifically contraindicated treatments, but things to consider when designing a program for CMT patients is that they often fatigue quickly due to their distal atrophy. High-intensity exercise and exercising to fatigue may exacerbate other secondary conditions. They also may have pain due to muscle cramping and fatigue and those muscular deformities such as pes cavus. Balance may also be an issue, so ballistic movements may increase their fall risk.